You are going to see this chart a lot in this PowerPoint. And I created it. I really like concept maps, and if you like them too, then these are really going to help you. So we are going to see this chart a lot as we continue along, and I'm going to keep referencing it so that we can kind of stay understanding where we are in the lecture. So each of these words means something different. Pharmacokinetics is basically what the body does to the drug. The body absorbs it, it distributes it, it metabolizes it, and it excretes it. And there's a whole bunch of fine details in there. So pharmacokinetics, what the body does to the drug. Pharmacodynamics is what the drug does to the body. So you'll notice that the drug is absorbed and distributed, and then the drug does something to the body. I have pharmacodynamics written in blue there, and then the body does something to the drug. It gets metabolized, it gets excreted, and I have a few arrows there pointing out the different pathways that the drug can take, and we will talk about each one of those. Pharmaceutics is basically an understanding of how we make drugs. That's going to be pertinent in our drug forms component of this lecture. And pharmacotherapeutics means how we use drugs. What's the therapeutic use of drugs? Why are we giving this medication to this patient? And in our week 1 lecture, I mentioned that you can give the exact same drug to do 2 different patients for 2 different reasons. For example, morphine can be a powerful pain relieving drug, and we use it for analgesia, for pain relief. You can also use morphine as a cardiac medication. So sometimes when people have heart attacks, for instance, or they have chest pain, angina, you can give them nitroglycerin. But if their blood pressure drops too much with nitroglycerin, then you can move to morphine or hydromorphone. You don't have to memorize that example right now. I'm just using it as an example so that you understand that the same drug can be given for 2 different purposes. So this is the flow chart that we're going to be following for the first part of our lecture. Let's start with absorption. So absorption, basically, the medication needs to get from its site of administration into the bloodstream, into systemic circulation. Some medications don't have very far to go. Some have a little bit further to travel. So some examples. When we take medications by mouth, also known as PO, if you see the abbreviation PO, that means taking something by mouth. That drug has to get through epithelial cells. Epithelial cells are cells that line body cavities. That's all epithelial cells are. They line the stomach, they line the intestine, they line organs. So they have to cross through this layer of cells to get into the blood in capillaries. When you take topical medications, so anything that goes on the skin, creams, patches, ointments, they have to cross layers of skin to get into blood vessels, so they're absorbed that way. When you inject medications into the muscle or into the subcutaneous tissue, they have to cross endothelial membranes to reach systemic circulation. Endothelial cells are just a single layer of epithelial cells. They're kind of the same thing as epithelial cells. It's just one single layer of them. So simply put, they just have to cross a layer of cells to get into systemic circulation. When you inhale drugs, the same exact thing happens. The drug has to cross the epithelial cells to get into capillaries. The exception to this is drugs given intravenously. So injecting a drug straight into venous circulation, it's already there. It's already in systemic circulation. So intravenous drugs aren't affected by this absorption step. So absorption is the medication getting into the bloodstream from wherever it was that you first administered it. There are many different factors that affect absorption, so let's go through some of the most important ones. The route of administration affects absorption. So intravenously administered medications, meds that are injected right into the venous system, there is no absorption step. So that this part discussion about absorption is not pertinent for intravenous drugs. They are 100% bioavailable. That means that no drug gets lost in the absorption step, and it's not affected by the absorption step. The oral route, so taking something PO, that's the abbreviation for by mouth. The oral step is probably the most affected by absorption. So when you take something PO by mouth, it's affected by the stomach pH, your stomach motility. Is there food already in the stomach? And what is the health and length of your GI tract? So let's talk about stomach motility first. This is going to be more and more pertinent as you continue in your career, because you are going to see more and more of the GLP agonists in your career. An example of a GLP agonist is Ozempic. One of the things that Ozempic does, and it does several things, but one of the things that Ozempic does is that it really, really slows down stomach motility. So that means that food and whatever you take by mouth, including medications, stays in the stomach longer than it normally would if you weren't on Ozempic. And so the therapeutic effect of that is it makes you feel fuller longer. So there's an appetite suppression effect from decreased stomach motility that comes with Ozempic. There's other effects of Ozempic, but this is one of them. So you're going to have medication sitting in the stomach longer if you are on a medication like that. If you are on a medication like metoclopramide, also known as Maxiran, that increases GI motility. That makes your stomach empty faster. So it's not as affected by the pH of the stomach. Presence of food. When we eat, there's something called the gastrocolic reflex. When we eat, the bottom sphincter of our stomach opens and our stomach contents empty into the small intestine to make room for the new food that's coming in. This reflex is really, really strong in babies. So for anyone that has ever fed a baby or a little kid, you may have noticed that as soon as they start eating, they start pooping, and that's because of this reflex. It slows down as we get older, but the presence of food, is there food coming in, affects our stomach motility. Health and length of the GI tract. People that have inflammatory illnesses like Crohn's disease, for example, they can have an inflamed GI tract, including an inflamed areas of the stomach and the small intestine. Inflamed areas don't absorb medications or even nutrients like healthy, non-inflamed tissue does. People with these inflammatory illnesses like ulcerative colitis, Crohn's disease, people that have had bowel cancers, sometimes they have parts of their small intestine or large intestine completely removed. So that means you have less surface area for absorption. So those are examples of how the health and the length of the GI tract affect absorption. If you are inhaling something, you are bringing it into the lungs, you are going to have rapid absorption because there's a large surface area, very, very rich blood supply, a lot of capillaries in our lungs, which means that there's a lot of places for the blood, for the medications to go. Once they get through those epithelial cells, there will be a capillary right there waiting for them to absorb the medication. If you are putting something through the skin, so a cream, an ointment, a medicated patch, it's going to be a slow and steady absorption. It depends on the lipid solubility. So lipid soluble drugs are generally absorbed faster than water soluble drugs. So lipid soluble and water soluble, if I said something lipid soluble, that means something dissolves really nicely in lipids. Water soluble means it dissolves really nicely in water. And the reason for that kind of comes down to how drug molecules cross biological membranes, cross cell membranes. So cell membrane structure, there is a phospholipid bilayer that makes up cell membranes, and it's made up of lipids. So that lipid-rich cell membrane is selectively permeable, and it allows lipid-soluble substances to diffuse easily. So lipid-soluble drugs are absorbed faster, generally. The drug formulation, the way that we formulate the drug, the way that it's put together can affect absorption. So for example, enteric-coated medications, you may have heard of enteric-coated aspirin. So that means that there's a special coating on it to prevent the drug from breaking down in the stomach, in the super acidic environment of the stomach. We don't want the drug to absorb there. We want it to go a little bit further down the GI tract, into the small intestine maybe, to be taken apart and then absorbed. Extended release is something a little bit different from enteric coated. Extended release means the effects of the drug last a long time. So that means that the absorption is going to be slightly different if it's an extended release formulation. The perfusion to the site of absorption affects the speed of absorption. For extremely well perfused tissue, absorption is going to be faster because, like I said before, the drug molecules are traveling through the layers of skin, let's say. And if, let's say it's traveling through muscle, skin and muscle is extremely well perfused. Subcutaneous tissue is not as well perfused as muscle is. There's less capillaries in subcutaneous tissue than there is in muscle. So if you gave someone an IM injection and you gave someone a subcutaneous injection, the IM injection would work faster. And then, of course, I mentioned drug characteristics. There are some drug characteristics that make drugs be absorbed faster or slower. So there's a few things that affect absorption. Now we are going to talk about the first pass effect, also known as first pass metabolism. So the drug has been absorbed, it has gotten into the capillaries, it is in our bloodstream. The first pass effect is when a medication is chemically changed after it is absorbed. So what happens when we take things PO by mouth is that they are absorbed into our stomach, or into our small intestine, or into our large intestine. Anything that's absorbed into those areas immediately goes to the liver. Components of our diet and drugs and medications that we take. It's absorbed into that portal circulation, it's called, and it goes right to the liver for the liver to basically figure out what's going on with this, change the chemical structure of these substances to either make it easier to excrete, make it easier for the body to use, make it easier for the body to change it again in the next metabolism. A whole bunch of things can be happening. That's what first pass metabolism is. It's when you take something by mouth and it immediately goes to the liver after it's absorbed, and the liver chemically changes it. So first pass effect, also known as first pass metabolism, it ends up decreasing the drug's concentration when it gets back to systemic circulation. So you swallow a drug, it's absorbed through the epithelial cells of your small intestine. It goes to the liver metabolizes it, changes it, and makes some of it inactive. There's some medications that actually first pass metabolism makes 100% inactive, so you can't give them by mouth. But in this example, the medication, some of it has become inactive in the liver, some of it has become inactive in the liver, and then it goes to the heart through the vena cava, the heart pumps, and it gets distributed throughout the body. So the first pass effect decreases drug concentration. The major site of drug metabolism is the liver. And there are big natural variations of the first pass effect from person to person, and there are also ethno-cultural variations between person to person regarding the first pass effect. So to sum up this slide, the first pass effect is when food or medications is absorbed from the GI tract into hepatic portal circulation. The liver does something to it. The liver releases it. It travels up to the heart beats, and then this medication is distributed all across our body. This is a slide summarizing hepatic portal circulation because I find a lot of people are kind of confused about it, and it can be confusing. So let's go through it. So hepatic portal circulation is part of the circulatory system. It carries blood from the digestive organs to the liver before it enters general circulation. So this is a way for your body to process substances that you eat or that you take PO, like drugs, before it can reach the rest of the body. So it's kind of a safeguard for our body, and it's also a way for our body to make substances more active so that we can use them better, or so that they can work on us better. So our digestive organs absorb nutrients from food, and of course they also absorb medications. When these digestive organs absorb nutrients, the blood doesn't directly go to the heart, First, it goes through the liver. So you have to go through the liver to get to the heart. It flows into the hepatic portal vein. The hepatic portal vein carries this blood to the liver. Inside the liver, these substances, meds, food, whatever, is processed. The blood then leaves the liver through the hepatic veins, and it goes to the heart, goes to the right atrium of the heart, goes to the lungs, it's oxygenated, and then it's squeezed out through the left ventricle. So the hepatic portal circulation is just a fancy way of saying that things that you take through your GI tract go to the liver before they're distributed to the rest of your body. So I mentioned something about IV meds in an earlier slide, and I also mentioned IM and sub-Q. So let's talk about how those work when it comes to hepatic portal circulation. So IV drugs are directly injected into a vein. So you might be wondering, how do they miss the liver? So IV drugs are put right into systemic circulation, so into your arm vein, for example. And then that, because veins are deoxygenated blood, it goes right to the superior vena cava, and then the right atrium, the lungs, it's oxygenated, then left atrium, left ventricle, and then out to the body. So when you give something intravenously, the liver doesn't even see the drug until it has circulated through the body once. There is overlap between the different portions of pharmacokinetics, but I'm just taking it step by step so it's easier to understand. So when you give something IV, the liver doesn't even see it until it's been circulated through the body once. And by the time it gets there, the molecules have been distributed, they've produced their effects, and then they can undergo second metabolism in the liver. So IV drugs bypass first pass metabolism. Intramuscular and sub-Q drugs also bypass first pass metabolism because they do get absorbed through the skin, through the muscle, through the subcutaneous tissue, whatever the case might be, and they go directly into the venous circulation as well, just like IV does. But IM and sub-Q drugs are affected by absorption. IV drugs are not affected by absorption because IM and sub-Q have to go through a few different layers of the body to finally get to the capillary, to finally get to the venous system. IV drugs don't have to do that. They're right in the venous system already. So IV drugs, IM drugs, and sub-Q drugs bypass first pass metabolism. IV drugs are 100% bioavailable because they bypass absorption. IM and sub-Q drugs are not 100% bioavailable because they are impacted by absorption. So that's the difference and the similarities between what's going on with IV, IM, and sub-Q routes of administration. This is just continuing our talk about the hepatic portal vein, a summary. Oxygenated blood goes to the digestive organs from the heart, goes to feed the digestive organs. Oxygen's dropped off, CO2 is picked up. What is also picked up are the medications and nutrients that are in the GI tract. And then the deoxygenated blood goes from the liver to the heart, and that's first pass metabolism. IV, IM, sub-Q drugs just go straight to the heart and then out to the system. So this is just another way of understanding the hepatic portal system. If you're wondering how do oxygenated and deoxygenated blood work into all this, well, oxygenated blood goes to the digestive organs, gas exchange is done, carbon dioxide is picked up, but what's also picked up are these medication and nutrients, and then it goes to the liver, that's first pass metabolism, and then it goes to the heart to become oxygenated and for the meds to be distributed. I think I covered this, but let's make sure we fully understand it. IV medications are 100% bioavailable, meaning you are getting 100% of the drug when it's injected. IM and sub-Q are not 100% bioavailable, but they all bypass the first pass effect. So IM and sub-Q are impacted by absorption. IV drugs don't have to be absorbed. There are a few more factors than what I have described already that reduce absorption. So I didn't talk about them yet because these are more specific to the IM and sub-Q formulation. So any area with poor blood flow, And whether that be just chronic poor blood flow or acute poor blood flow, like you are in shock or you are severely vasoconstricted, there's just not a lot of blood flow going to the area, that's going to impact how IM and sub-Q drugs are absorbed. The drug formulation. So it's called depot injections, and those are things that last really long intramuscularly. You can get antipsychotic drugs as a depot injection. You can get contraceptives as a depot injection, and they slowly absorb because of the formulation. So obviously that is how absorption affects them. The injection site. If you have a really big solid muscle mass on the person you are injecting intramuscularly, you are going to have better absorption. Really good muscle mass means really good absorption because there's more capillaries. Fat thickness. If you have a larger surface area of fat, that is going to affect absorption. And we mentioned molecular size already. And then local reactions. So as you guys will learn in other classes, when you go to administer an IM or sub-Q, you have to make sure it's not an area where there's a scar, because scar tissue has really poor perfusion. So the summary of this slide is to understand that IV is 100% bioavailable. IM and sub-Q are not, but they all bypass the first pass effect. We're just pausing here at this slide to make sure we still know where we are in this concept map. So we talked about absorption, drug getting into the bloodstream. And now we are talking about first pass metabolism, also known as the first pass effect. We're going to talk a little bit more about first pass metabolism, and then we are going to get into distribution. You will notice I have the word prodrug written in yellow in 2 spots on this concept map, and I'm going to explain prodrugs as well. So we talked about absorption, we started talking about first pass metabolism, we're going to get into that a little deeper, and then we're going to get into distribution. So we're still in our pharmacokinetics discussion. Some drugs have such a heavy first pass effect that you cannot even give them PO because they won't have any effect on the body. So an example of that is nitrates. You have probably heard about nitroglycerin. It's a cardiac medication. It's a coronary artery vasodilator and also a venous vasodilator. Nitrates are metabolized by the liver so extensively that they won't work if you were to give them PO. So you have to give them through a route that bypasses the first pass effect. You can give nitroglycerin sublingually. It's a spray, nitroglycerin spray. You can give it topically. There's nitroglycerin patches that you will see in clinical rotations. And you can also give it intravenously. So nitroglycerin can be given intravenously in critical care environments. Probably what you're most familiar with is the spray nitroglycerin. But in clinical, you will also see patches of nitroglycerin, and these are all for cardiac patients. So there's some medications you just cannot give PO at all because of how heavy the first pass effect is. What about the rectum? I have questions about that. What about rectally administered drugs? In our first class, I mentioned how I have given ketorolac rectally. You can also give Tylenol rectally. I've given antibiotics rectally. Of course, the locally acting bowel care meds for constipation you can give rectally. So what happens with the first pass effect and rectally administered drugs? It depends on where within the rectum these drugs are making contact. So the upper rectum connects to, those capillaries connect to the superior rectal vein, and then they go to the portal vein, and then they go to the liver. So blood here goes to the liver first, and so it is subject to first pass metabolism. So if you gave a medication that made its way up to the upper rectum, it would be absorbed into those capillaries of the upper rectum and then eventually get to the liver. So it is subject to first pass metabolism. The lower rectum, the capillaries that feed the lower rectum and take deoxygenated blood away from the lower rectum, I should say, those connect to the middle and inferior rectal veins, and basically it bypasses the liver and it avoids first pass metabolism. So long story short, you can never be 100% sure when you give something rectally how much of what you give is going to be subject to the first pass effect. But you can pretty much be sure that if you give something rectally, it is going to bypass the first pass effect. I'm going to give you guys a hint here I have some practice questions and some possible questions on the midterm about bypassing the first pass effect. And I want you guys to remember that sometimes it does, sometimes it doesn't. It's not 100% sure either way, because when you give something rectally, some of it could end up in the upper rectum and then be subject to the first pass metabolism. So giving something rectally, we're not quite sure either way, but probably most of it does bypass first pass metabolism. Why is the first pass effect relevant for nurses? Why am I teaching you so much about it? It's so that we can understand a few things. Number one is that the route through which we give a medication matters. And sometimes as a nurse, you will be choosing the route because the doctor has ordered several different routes and you pick which one you are going to administer the medication by. So we need to know that some routes bypass the first pass effect. We also need to understand that there are some drugs, and they're called prodrugs, that require the first pass effect to become activated so that they can work. And I'm going to teach you more about prodrugs in future slides. We need to understand why there are sometimes enormous dosing differences between intravenous meds and meds that you are not giving intravenously. So for example, if I'm giving morphine, if I gave it intravenously, I would give a much, much, much smaller dose than if I was giving it orally. I would give 0.5 milligrams IV instead of 5 milligrams PO. Drug effectiveness is impacted by the first pass effect. Let's say you are someone with a very high first pass metabolism. We know there's differences between people. There's going to be less drug in circulation and therefore a weaker effect. There's a group of people, and they're called super metabolizers, and you guys can Google it if you want. I think it's a genetic alteration. I'm almost 100% sure it is. They're called super metabolizers. They take a medication, a potent, powerful medication, and it has absolutely no effect on them. So if you want to learn about super metabolizers, it's kind of interesting. I've never seen a super metabolizer in my career, but it's just something kind of interesting to know about. We need to know about the first pass effect for safety reasons. So there are people with liver disease, or for some reason they have impaired metabolism. Drugs are going to build up and build up and build up because the liver isn't taking them apart properly, not deactivating them properly. And so therefore you're going to have a toxicity risk. If your liver doesn't work as well as the average person's liver, and drugs don't get metabolized, which means taken apart, some of it becomes inactive, you're going to end up with more drug in systemic circulation because the liver hasn't deactivated some of it like it's supposed to. So you need to be aware of the liver function tests, something you're going to learn about in other classes. So we have an awareness of how the meds we are giving might be processed. So if I had a patient with liver disease and I was giving them a medication that was metabolized in the liver, giving it to them PO, I have to be aware of there is an increased toxicity risk for this medication. Patient education. Patients might ask you, hey, why do I have to take this gross nitro spray under my tongue? Why can't I just swallow a pill? There's some drugs that just can't be taken orally because they're completely deactivated by the liver. And of course, it's pertinent for our nursing practice. Helps us understand what route to choose, what dose to choose. Sometimes physicians order a range of dosages and we can pick which dose. And monitoring drug response. Understanding the first pass effect helps us monitor drug response. There are many reasons why we may not want the first pass effect, why we may want 100% bioavailability. There's several reasons why. When you give something with 100% bioavailability that bypasses absorption, like intravenous medications do, you get an immediate effect. And so that is really, really good in emergencies. For example, people in pain crises. So on the surgical ward, sometimes occasionally people will end up with completely uncontrolled pain and we need to get it under control. So intravenous morphine can be really helpful for that. It works right away. Emergency airway situations like anaphylaxis, intravenous epinephrine works right away. So an airway emergency is a super high priority emergency. So IV drugs are really ideal because they don't have to be absorbed. They're just getting right to the distribution step. It allows for very precise dosing because there is no variability from absorption. Doctors can titrate dose to effect more accurately. What does that mean? That means that when you are giving someone an IV insulin drip, you can continuously monitor their blood glucose, and you can see immediately in front of you what happens to the blood glucose when I turn up the IV insulin a little bit. What happens to the blood glucose when I turn down the IV insulin a little bit. You get immediate feedback for your clinical decisions when you have an IV drip. Same thing with IV heparin, anticoagulant. Nickname for it is a blood thinner. There's blood tests we can do to see how much the blood is capable of clotting or not. So you can titrate the dose to effect. So what is this dose doing to the person? You can be really accurate. There are many clinical situations when oral absorption is just not possible. People are vomiting too much to swallow anything. People are unconscious. They can't safely swallow something. They are not allowed to eat or drink because of their surgical status. Another example is someone that is in sepsis. So sepsis is a systemic response to infection, and it's a huge inflammatory response. Inflamed tissue doesn't work as well. It doesn't do its job as well as non-inflamed tissue. So when people are in septic shock or sepsis and you give them something orally, you cannot rely on their absorption to work like someone who does not have that inflammatory response. So IV antibiotics are given for people in septic shock, so then we don't even have to worry about these absorption problems. There are some drugs that have extremely poor bioavailability. They're destroyed in the gut. An example of a medication destroyed in the gut is insulin. You can't give insulin PO because it's destroyed in the gut. There are some medications, like I mentioned before, that are completely destroyed by first-pass metabolism. So an example of this, there's an antiarrhythmic called lidocaine. You may have heard of lidocaine before as a numbing agent. Well, it's actually also an antiarrhythmic. Makes your heart go into the proper rhythm when it goes out of rhythm. Vancomycin is another medication that's often given IV. It can be given PO too, but mostly it's given IV. And then the tight control in critical care environments. So really, really critical medications that have a narrow therapeutic index, and I'll explain what that is. We can adjust the rate second by second based on how the patient is responding. So that's really closely related to the precise and predictable dosing. All right, so we have gotten through absorption. We have gotten through first-pass metabolism. I haven't fully explained prodrugs, but I will continue to do that. And now we are at distribution. The medication is in the bloodstream. It was either injected or it has gotten there from the hepatic portal system, and it's in the bloodstream. So distribution, this step, is the process of drugs being transported throughout the body. Makes sense that drugs are going to go to places where there's an extensive blood supply first. And distribution is hugely affected by a molecule in our body called albumin. So albumin is a protein that floats around in our bloodstream that's made by the liver. And albumin does many, many different things. And one of the things that it does is that it loves to bind other molecules. It loves to bind drug molecules especially. When a drug molecule that has been absorbed and gone through first pass and gets into the bloodstream, when it binds to albumin, it's inactive. It floats around in the bloodstream and it can't do anything. Only the medications that are unbound can actually leave the vessels and reach their target cells and tissues to have an effect. Because albumin is too big to get out of vessels. People tend to think that vessels are completely watertight, completely airtight, nothing can leak out of vessels. Actually, vessels are pretty leaky, and we rely on that vessel leakiness for drugs to get out of vessels and reach cells and tissues to have their effect. Albumin is too big to get out of vessels. So that means that bound molecules connected to albumin can't get out of vessels, and so that's why they're inactive. They literally can't get to where they need to go to have an effect. So albumin status affects medication distribution. People with low albumin, so this low amount of this plasma protein, like with malnutrition, like with liver compromise, because your liver literally can't make the albumin because you have lost it from severe burns. If you have low albumin, there's less protein for the drug to bind to, and that means there's more free drug available to leave the vessels, and that means there could be stronger drug effects and maybe even toxicity, even if the dose is normal. So this is one of the reasons why, there's many reasons why, but this is one of the reasons why drugs sometimes affect older people differently, because older people tend to have low albumin, and there's a variety of reasons. One of the reasons is that older people don't absorb protein like younger people do, and it's from the protein that we eat. The liver takes it apart and puts it back together and makes albumin. So if you're not absorbing enough protein, you're going to have low albumin. If you're not eating enough protein because you're a little old lady and you don't have the hunger and thirst cues and you get full really quick, and maybe you're just cooking for one so you don't feel like making a big meal, you are going to have low albumin. So malnutrition states are very, very, very common. Low albumin is really common. If the patient has high albumin, that can affect distribution as well. High albumin is pretty rare. I don't know if I've ever actually seen a high albumin state, except for a couple patients that were using anabolic steroids. Iatrogenic means it's caused by healthcare. Sometimes we give people albumin infusions. So you can have high albumin from an albumin infusion, but it gets cleared eventually. So what you need to know from this is low albumin states are way more common and they happen way more often. I can probably count on one hand when someone has had a high albumin and that affected their drug distribution. So the key learning from this slide is that albumin affects drug distribution because drugs can't get to target cells and tissues when they are connected to albumin. And if there's no albumin there, that means there's a lot of drug that's going to get to target cells and tissues. Another really important factor that affects drug distribution is barriers. So there are several barriers in the human body that really protect different parts of the body and limit what drugs can actually get into that part of the body. They're not perfect. The barriers are not perfect. The one that you might know the most or may have heard of is the blood-brain barrier. So the blood-brain barrier basically just means that blood vessels that feed the brain are not as permeable as the rest of your body's blood vessels. So you can see in the picture on the left-hand side that blood vessel has pores. It's permeable. Substances can leak out through the walls of blood vessels. You'll notice in the brain blood vessels, there are no pores like that. There's tight junctions that create the barrier. So the reason for this blood-brain barrier is you can see that the blood vessel on the right-hand side is surrounded by nerve cells. It's surrounded by the nervous system, the central nervous system, which is what the brain is. So it's protecting those nerve cells, your nervous system, from anything that could possibly harm them. So the blood vessels on the right-hand side have tight junctions. Substances cannot easily leak out and touch those neurons, those glial brain cells in the case of this picture. The blood-brain barrier is not perfect. Things can get through the blood-brain barrier. Alcohol, for example, carbon monoxide. We're going to learn about the anesthetic gases and how we want them to get through the blood-brain barrier so we can get a deep sedation effect. Different bugs and viruses, Bacteria and viruses can get through the blood-brain barrier, so it's definitely not perfect. Another barrier you may have heard of is the placental barrier. So that protects baby from substances that mom might be ingesting, and again, not perfect. And there's another barrier in the human body, and it's in the testes. There's a barrier there as well. So that affects distribution. It affects the movement of medications in the body. pH, drugs move more easily into areas of similar pH. So if tissue is inflamed, like in the case of an active infection, like in the case of sepsis, drugs might not be able to penetrate well because inflamed tissue has a different pH than it normally does. Body water distribution affects distribution of medications. Babies have more body water, elderly have less body water. Body fat composition, and of course we know disease states can affect distribution. So those are just a few of the things that affect distribution of medications. All right, so we have gotten through the first two steps of pharmacokinetics. We have talked about absorption and distribution and mentioned first pass metabolism in there. That is what the body is doing to the drug. Pharmacodynamics is when the drug reaches its site of action and has an effect. So there's kind of a little break in pharmacokinetics here where the drug is doing something to the body, and then we go back to pharmacokinetics. So I'm just going to mention pharmacodynamics here, and then later in the PowerPoint, we are going to get more into detail. So I'm going to mention pharmacodynamics, and then we're going to get into metabolism and excretion. So after distribution, the medication has left the capillaries, it has got to its target tissue, it has got to its cells. It is going to have an effect on body cells and body tissue. Some examples: you breathe in a puffer, a bronchodilator, also known as salbutamol, Ventolin. You inhale it. It's absorbed through the epithelial cells. It's distributed locally in the lungs, flowing throughout the capillaries of the lungs. It gets out of the capillaries and it binds to cells and causes bronchodilation. Morphine, you give a dose of morphine. Morphine crosses the blood-brain barrier, binds to receptors, and causes analgesia. So those are just two examples of how absorption, distribution, and then pharmacodynamics happens in order. That's just mentioning pharmacodynamics, and I'm going to talk about it more, but right now we're going to continue with pharmacokinetics and talk about metabolism. So we talked about metabolism already. We've talked about first pass metabolism. So now we're talking about second pass metabolism, and it's never called that in academic literature, but I just want you guys to know I'm talking about the second metabolism that happens. If you see in academic literature the word metabolism, they're talking about the metabolism that happens right before excretion. If you see first pass metabolism, then they're talking about first pass metabolism, the one that happens between absorption and distribution. So, metabolism, we know that is just blood circulating through a metabolizing organ, and enzymes in that organ turn the drug into something else. Changes it into something easier to use, easier to store, easier to get rid of. Same thing happens in first pass metabolism. Metabolite is just a fancy way of saying what is formed when the body changes the structure of a drug or a substance. That's what a metabolite is. Metabolites can be totally benign, meaning they don't have an effect, they're not harming you. Metabolites can be toxic, meaning they can have a negative effect on your body if there's too many of them. So that's all a metabolite is. It's just something that used to be a drug and it got changed. Mostly this metabolism makes a certain percentage of the drug inactive. The liver is the main metabolizing organ, and it does this through a family of enzymes called the cytochrome P450 enzymes. There's a lot of them. And these enzymes also metabolize dietary compounds, but we're just going to talk about drugs here in this lecture. So there's a family of enzymes in the liver, and they're called the cytochrome P450 enzymes. The kidneys are mostly involved in excretion, but they can also metabolize some drugs, but the kidneys don't really do any first pass metabolism. So right now we're talking about the metabolism that happens after pharmacodynamics in the liver through the cytochrome P450 enzymes. First pass metabolism also uses the cytochrome P450 enzymes, but now we're going to get more into detail about them. Prodrugs. I mentioned that I was going to talk about prodrugs. So an active drug works as is. You take it, metabolism inactivates it, prepares it for excretion, keeps some of it the same so that it can work. That's an active drug. A prodrug you can never give intravenously, because a prodrug is a substance that you need first pass metabolism to activate it before it can exert any effect. Mostly it happens during first pass metabolism. And it can also happen during second metabolism, but most prodrugs are activated during first pass metabolism. So codeine is an opioid, but you would never give it intravenously because it is so weak, it doesn't really work until it gets through first pass metabolism. It relies on the cytochrome P450 enzymes to convert it into morphine. So codeine, if you did a safe dose injection of codeine, you wouldn't really have any pain relief at all. If you took it orally, it changes into morphine and you would have huge pain relief. So codeine is a prodrug. You need first pass metabolism to make it work. Why are prodrugs a thing? It seems like why would you even bother with a prodrug? There's a few different reasons why they're listed here. You don't have to memorize this slide. I just want you to understand that there are reasons why there are prodrugs. Another reason why there are prodrugs is because the creation of pharmaceuticals is very imperfect. There's still a long way to go to make drugs exactly how we want them. So that's another reason why prodrugs exist. All right, so that is metabolism through the cytochrome P450 enzymes. And now we move to excretion and elimination, in which the drug is removed from the body. Usually this happens in the kidneys. Let's go through this step by step. The first thing you need to know to understand this slide is that filtrate, you can kind of think of filtrate as pre-urine. It's going to turn into urine. So things can go into the filtrate and things can come out of the filtrate depending on the body's needs. So this is the excretion process for drugs that are excreted renally. What happens first? The substance gets to the kidneys. It's in the capillaries of the kidneys. And it moves from the blood into the filtrate. So the body's getting ready to pee it out. Only free drugs can move from blood into filtrate. Protein-bound drugs stay in the bloodstream. Okay, so we have substances. Some have moved into the filtrate, into the pre-urine, what's going to be urine. Some have stayed in the bloodstream. What happens next? Sometimes what happens next is that substances are pulled back from the filtrate back into the bloodstream. This doesn't happen all the time with all substances, but that's what reabsorption is. It's the body deciding, hey, I was going to pee this out, but actually I'm going to bring it back into the bloodstream. This step obviously reduces the amount of drug that's eliminated. Tubular secretion is another step that can happen. So substances that were not filtered in step number 1, for example, the protein-bound drugs, they can move further into the glomerulus and go from the blood into the filtrate. So protein-bound drugs can leave the blood here. It's just a different part of the glomerulus where that happens. And then finally, excretion. Whatever is in the tubular fluid becomes urine. So the filtrate that is in the tubular fluid becomes urine and leaves the body. So this is a very simplified understanding of the renal drug excretion process. Basically, substances move from blood into the urine, into the filtrate, another way of saying it. The body might decide, hey, actually I'm going to pull that back and keep it in the bloodstream. Protein-bound drugs can leave at a further down this process. And then you can pee everything out that your body doesn't want to keep anymore. That's what excretion is. What about reabsorption? So I mentioned reabsorption. the return to systemic circulation. So your body decided, let's put this in the filtrate, and then decided, oh no, actually I want it in the blood vessels instead. What effect does this have on the body? It prolongs the half-life of the medication. I'm going to explain what half-life is. Basically, it means it makes the drug's effect last longer because you've pulled it back into the bloodstream, and now maybe it's going to make another pass throughout the body. It's going to have an effect again, and so that might be good. We may want a prolonged half-life. We may formulate drugs so they are reabsorbed so that they can last longer. This can also be a negative thing. So if your kidneys aren't working properly and it's reabsorbing, your kidneys are reabsorbing substances that they're not supposed to be reabsorbing, that can be bad because there's a risk of accumulation or toxicity. The kidneys aren't the only organ that can eliminate medications or substances. You can also eliminate medication or substances through your intestines, through feces. So what happens here is that the liver picks up the drug from the blood, puts it into bile. The bile goes into the gallbladder. The gallbladder empties out into the small intestine, and then the drug is eliminated in feces. Just like the kidneys can reabsorb, so can the intestines, and is called enterohepatic circulation. In the next slide, I have a flow chart that explains both these kinds of circulation, but let's just go through this slide first. So the drug has been metabolized. It's ready to be, it's gone, it's had its effect, and now it's ready to be secreted in the bile. It's released into the small intestine through the gallbladder. What happens then in this kind of reabsorption is that the drug is reabsorbed into the capillaries of the small intestine, and it goes back into portal circulation, back into the liver. And from there, it can re-enter systemic circulation. And that's what I have summarized on this chart so that we can understand where and why reabsorption is happening. So we've taken a drug. It has gone through the GI tract and has got to the liver and undergone first pass metabolism. Then it's distributed through the body and it reaches the tissues and it has an effect, and then it goes back to the liver. And from there, it can either go to the kidneys and go through glomerular filtration all the way to elimination that I discussed in a previous slide. We know that reabsorption can happen here, and that's the red arrow I have. It's reabsorbed in the kidneys. It's pulled back from the filtrate into the blood. The body decides, hey, I want to use this some more. And it goes back into circulation and back into the tissues, and on it goes. What can also happen is from circulation, it can go to tissues and then the liver and then to bile and then to small intestine. But here we have the enterohepatic circulation. The red arrow, it's reabsorbed into the intestines. It goes back into circulation, back into the tissues, has more of an effect, and then back to the liver. So that is reabsorption summarized. The kidneys can reabsorb, and the small intestine can reabsorb, and it could be a positive or a negative thing. There are other ways to eliminate drugs. You can exhale them. A small amount of alcohol is eliminated in your pulmonary system, just a small amount, but that's how breathalyzers work. Anesthetic gases. So when you are exhaling after you've gone under general anesthetic, you are actually clearing general anesthetic drugs, the drugs used to put you asleep. Sweat and saliva. There's some actually all chemotherapy drugs. When people are on chemotherapy drugs, they have to be very mindful about how their body excretions. Basically, their sweat can be toxic to other people's cells because chemotherapy is toxic to cells. So people that are on chemotherapy have to be very mindful of even their sweat because it can harm other people in their household. Some meds are excreted in breast milk. Actually, many substances can be excreted in breast milk. Tears, it's very rare, but I just included it because it's interesting. There's an antibiotic called rifampin. It's for tuberculosis, and it can actually make your tears turn orange, and it can stain your contact lenses. And rifampin also makes your urine a really, really funny shade of kind of reddy orange too. So those are just other ways to excrete medications. Here's a summary of some of the things that we have talked about related to pharmacokinetics. Absorption, drug gets into the bloodstream. It gets through epithelial cells. It gets through endothelial cells, which is just a single layer of epithelial cells. It travels around. It's bound to albumin. Some of it's not bound to albumin. Some of it gets into tissues and then attaches to cells and has an effect. Some stays in circulation. It's metabolized after it's had its effect, which is just another way of saying it's chemically changed. And then it's excreted. So this is a summary of pharmacokinetics. Some definition words we need to know under the pharmacokinetics umbrella. Half-life, I've mentioned this. So half-life is simply the definition here, the amount of time it takes for the concentration to be reduced by half. Most drugs are cleared after about 4 to 5 half-lives. If someone says this drug has a long half-life, that's another way of saying that it lasts a long time. If someone says a drug has a short half-life, that's another way of saying that it has to be taken more frequently. There's some medications, intravenous medications, that have a half-life of less than 10 seconds. There's a cardiac med that has to be injected into a vein very close to the heart because we want the drug to get to the heart and have an effect. And if you inject it in a vein that's too far away from the heart, it will be completely useless by the time it gets to the heart. That's how short a half-life can be. I've had this question before. Why are we worried about a half-life? Why don't we just worry about a duration, like how long it works? Why are we worried about how much time until half of it is gone? The reason is that when we're worried about duration, how long something works, it does tell us about how long the therapeutic effect lasts, but half-life is much more specific in that it tells us how much drug is actually in the bloodstream. It tells us when to give the next dose, and it tells us when the drug can be building up to dangerous levels. So taking a medication and deciding when to take the next dose based on how long it seems that the drug is working for could potentially push you into a toxic dose territory. So let's say I took a gram of Tylenol because I had a really bad headache and the headache wasn't going away. And an hour later, I decided to take another gram of Tylenol without considering how much Tylenol was still in my bloodstream and only considering how is this medication working for me. I could build up the acetaminophen to a toxic level and harm my liver. That's an extreme example, but that illustrates why we need to think about half-life and not just duration. It lets us figure out how the drug is cleared. Adenosine was the medication I was talking about. It's cleared in less than 10 seconds. Narcan lasts half-life 30 to 90 minutes. You'll notice there's variations in half-life between people, but it is much more exact than duration is. Understanding half-life helps you understand safe discontinuation and tapering. There are some medications that you cannot stop abruptly, and it's for half-life purposes, and we will talk about them. And there are some drugs that you do not have to taper. The body naturally tapers itself off. And half-life also helps you understand that there are some drugs with a narrow therapeutic range, and I will explain what that is. Half-life can help you understand that. I am not going to ask you on any exam to calculate a half-life. I will never ask you to calculate a half-life. I just want you to understand the concept. Here's some more words pertinent to our discussion of pharmacokinetics. The reason we measure peaks is that some drugs need a certain peak level to kill bacteria, so we need to get them to that high level to achieve the desired effect. We need to make sure that they've reached that level, otherwise they won't work. So there's some antibiotics we need to get to a certain level, otherwise they will be ineffective to help the patient. Why do we measure troughs? If trough levels are too high, that means the drug is accumulating and we have a risk of toxicity. If the trough levels are too low, that means that we don't have effective coverage between doses. So let's say I took an antibiotic at 8 o'clock in the morning and it was to be given every 24 hours. And let's say that I got a great peak level, I got a great concentration level, it's working, But then the next morning, my trough was measured and I had absolutely no antibiotic in my bloodstream. That means that I don't have antibiotic coverage for the full 24 hours. The trough is too low. So I'm not getting the medication's effect for the full 24 hours when I need it. If the trough levels were too high when you measured it at, let's say 7:30 the next morning, and the dose was due at 8 o'clock, and the trough levels were too high and I took my next dose, I could be at risk of toxicity. So all these things are basically used to make sure that the drug is in the therapeutic range. It's effective, but it's not going to cause toxicity. There are some drugs with an extremely narrow therapeutic range, meaning there is not a big difference between an effective dose and a toxic dose. An example of this, so a too high of a peak, that is increased risk of toxicity. So there are some medications, some antibiotics, the aminoglycosides, that can cause permanent hearing loss when you get to the toxic levels. And they have a very narrow therapeutic range, so they're dangerous. The peaks and the troughs have to be carefully measured. If the trough was too low, that means that the drug is not effective. So a narrow therapeutic index means that you have to be very mindful of the peaks and troughs, because you could easily go into toxic and you could easily go into ineffective concentrations. Here's a clinical situation illustrating it. Bethany Frankel has an infection in her heart, in the lining of her heart, and she is getting IV vancomycin. It has a very narrow therapeutic window. So her blood is drawn after the dose to see what's the peak concentration. Is it enough to kill the bacteria? The blood is drawn right before the next planned dose to make sure that it's not too high and we're pushing this person into toxic levels, like ototoxicity. You can get permanent hearing loss from high doses of vancomycin. And so the pharmacists use these numbers to figure out what is the next dose of vanco going to be. So when you're in clinical rotations, you may see a doctor's order that says, or a pharmacist order that says, do not give next dose of vanco until trough is drawn. This means that you need the blood test. The pharmacist has to look at the trough level, and then the pharmacist will change what the next dose of vanco is going to be. It may have been 750 milligrams. Oh, they're going to change it to 500 milligrams because the trough is a little bit too high. So dosages are adjusted based on peak and trough. Some more definition words: onset, peak, and duration. Onset, when does it start working? Peak, when is its maximum effect? And duration, how long does it last? Every medication has an onset, peak, and duration. It can be very helpful to know these things for clinical purposes. For example, insulins. So if I gave someone a intermediate acting insulin like Humulin N, and then I noticed, wow, this person's blood sugar always crashes mid-afternoon. It's going to be helpful for me clinically to know, oh, that's when the Humulin N is peaking. So maybe their dose of Humulin N is a little bit too high. Insulin onset, peaks, and durations are really handy to know. In your drug guide, you will always see onset, peak, and durations. It's really hard to memorize all of them, but you will get to know a lot of them as you continue on your clinical practice and keep looking up a lot of medications. Aging changes pharmacokinetics. I've mentioned a few of these things throughout this PowerPoint: the albumin levels, the water composition, the fat composition. But this is just a summary of all the age-related changes and some clinical examples. Let's summarize the role of the liver in pharmacokinetics. The liver makes albumin. The liver does first pass metabolism. The liver does the quote-unquote second metabolism. The liver is involved in creating bile, which then goes to the gallbladder, which then goes to the small intestines, and drugs are excreted that way. So the liver has a huge role in pharmacokinetics, and so does the kidneys. The kidneys have a huge role in pharmacokinetics. Here's all the reasons why. If you have a problem with your kidneys, which you may learn about in your pathophysiology classes, you are going to have a little bit different way of, your body's going to handle pharmacokinetics a little bit differently. Let's have an example, clinical example. Dorinda Medley in pharmacokinetics. So she is 82. She has an irregular heart rhythm, high blood pressure, and osteoarthritis. She's getting digoxin. Digoxin is a medication that controls heart rate. And she's also getting naproxen. That's an anti-inflammatory painkiller. She lives alone, and her kidneys don't work that well. And we know that from her creatinine clearance. It's a little bit high, so she's not getting rid of creatinine like she should. Over the past 2 weeks, she has noticed some symptoms. She's tired, she's not eating, everything has a yellow tint. On your assessment, she has a low heart rate of 48 is low. Blood pressure seems okay, but her labs have elevated digoxin levels, so there's too much digoxin in her bloodstream. So what has happened with Dorinda that has led to these problems, including increased digoxin in her bloodstream? Absorption, it's slightly slow in the elderly person, but it's not going to hugely affect digoxin absorption. Distribution of drugs. When you're older, you have less muscle mass usually, and you have less body water. You have higher body fat, which means that drugs like naproxen, which really like fat, are going to be distributed differently. They are going to accumulate more. Her metabolism is slightly different than a younger person. Drugs aren't metabolized as well. And the excretion step is the most significant for her. So her kidneys are not excreting like they should be. And we know that because her creatinine is too high. Digoxin is renally excreted. Her kidneys are not getting rid of digoxin like they should, which means that the that's the short version of digoxin. You'll hear nurses say that the dig is staying in her system longer. And that means she has too much dig in her bloodstream. And that's why it's elevating to the toxic levels and giving her a yellow tint in everything she sees. She has digoxin toxicity, and it's from the excretion step mostly. But the other steps are impacted too. So what happened here? The doctor DC'd the naproxen, changed her digoxin dose, and they closely monitored her kidney function. All right, so we got through all of pharmacokinetics. We got through absorption, distribution, metabolism, excretion, with a quick stopover in first pass metabolism and a quick stopover in prodrugs. I mentioned pharmacodynamics, and I said we're going to come back to it. This is when the drug gets to the cells. It has its effect. So now we are focusing on pharmacodynamics, what's written in blue right in the middle here. Pharmacodynamics is what drugs do to the body. We talked about what the body does to drugs. Now, what do drugs do to the body? There's a lot of definitions we have to learn here. So let's go through it. Drugs exert their effect by interacting with cells. Many drugs interact with receptors on cells or inside of cells. There's definitions on the next slide that are very important for you to know because spoiler alert, you're going to get a lot of test questions about them. So I'll make sure you guys understand them. So how drugs interact with receptors have different definitions, words, and we're going to talk about those. So more definitions. Efficacy and potency, easy to get mixed up, but they're different things. Efficacy is the ability of the drug to produce the desired result. So the analogy is, how high can a ladder take you? Basically, how good a drug works. So morphine is very efficacious, works really well to get rid of pain, more so than, let's say, a Tylenol. Morphine is more efficacious to get rid of pain than Tylenol is. So it's how much, in this analogy, is how much pain relief you can get, how high up the ladder you can go. Potency is something different. Potency is how strong something is, how much drug is needed to get that result. So something is very potent, you need a smaller dose. So an example of this would be, I'm sure everyone by now has heard of fentanyl. Fentanyl is much, much more potent than morphine. You need a smaller amount of it to get the same result. a smaller dose. There are some things that make drugs more potent, like malnutrition, and we know why, because if you don't have enough albumin, you have a lot of free drug floating around. We're going to talk about the genetic differences in the cytochrome P450 enzyme system, and also aging with the body water and the fat composition changes and the pharmacokinetic changes that we talked about already. Potent drugs don't mean that they're better. Potent just means you need a smaller dose. So you might be thinking, well, why aren't we just giving the most potent, because we always want to give the smaller dose? Sometimes there are drugs that are just cheaper, they're more well studied, they're better understood. You can get them in many more forms. They work in many different clinical situations all across the board. So sometimes you're going to use a less potent drug even when there is a more potent one available. And this slide is just a summary about everything I just described about potency and efficacy. Now we are moving to receptor action. This is a slide that you have to know really well, and the next slide too. You have to know the definitions of agonist, partial agonist, antagonist, competitive antagonist, and non-competitive antagonist. I gave clinical examples. You do not have to memorize the clinical examples. I just gave them so that you could maybe understand it a bit better. For this slideshow's purposes, I'm not going to ask you about drugs when I test you on this slideshow. I may eventually test you on albuterol or naloxone, whatever the case might be. But for this slideshow purposes, I'm just using those drugs as examples. So, an agonist. This is when the drug has finally reached the cells. It's been distributed and it's got to the cells. It produces a full response on the receptor. So albuterol is a beta-2 adrenergic receptor agonist. All that means is that it binds to a receptor that's called beta-2. The other thing that binds to beta-2 is adrenaline, also known as epinephrine. Epinephrine and adrenaline are the same thing. So when you say beta-2 adrenergic receptor agonist, you are saying that you're binding to the same receptor that epinephrine binds to. So it has the same effect as epinephrine. What does epinephrine do? It dilates your bronchioles, causes bronchodilation. So when you have an agonist and you bind to a receptor, you are producing the effect that receptor typically causes. When you bind epinephrine to beta-2 receptors, you get bronchodilation. When you bind an agonist to a beta-2 receptor, you get bronchodilation. Produces the full response. Compare that to a partial agonist. It binds to the receptor, but it doesn't have the full response. It's also called an agonist-antagonist, which I kind of find confusing, so I like to call it a partial agonist. It works, but it doesn't have the full effect. An antagonist binds to the receptor and it blocks agonists from binding. So if you gave someone a medication that blocked epinephrine, it doesn't let epinephrine bind, an epinephrine antagonist, you would end up with the same result as blocking epinephrine. So the drug binds to the receptor, but it causes no effect. It just stops anything else from binding to it. So as another example, naloxone binds to opioid receptors, and it's a really strong antagonist. It kicks off opioids from opioid receptors. That's how strong it is. And it can reduce respiratory depression. Competitive antagonist. So this is an antagonist that wants to bind and block everything, but it's not that strong, so it can be outcompeted. So if you took too many benzodiazepines, if you overdosed on benzodiazepines, you would take an antidote called flumazenil. So you took too many benzos. You want those benzos off your receptors, so you're going to take flumazenil. The thing about flumazenil is if you have enough benzos on board, those benzos can outcompete it. So you can have too many benzos on board for it to work really well. So a competitive antagonist, it will work, but it's competing with the agonist, and sometimes an agonist can outcompete it. Non-competitive antagonist, it's just completely shut down. It can't be overcome by more agonist. So ketamine binds to the NMDA receptor and blocks something called glutamate. And so it completely blocks glutamate. It doesn't let glutamate attach. No matter how much glutamate is present, it's not going to be outcompeted. So it can't be overcome, unlike a competitive antagonist. Here's another summary. There's a video there from Osmosis. That's how important it is for you to know these things, because throughout the rest of the class, I'm going to say things like, this med is an antagonist, this med is an agonist, this med is a blocker, also known as an antagonist. So it's going to be really helpful if you know what these words mean so that you can easily understand those statements. I want to explain partial agonists more. So an agonist fully turns a receptor on and it produces the effect. Like morphine, it binds to the mu receptors, full pain relief. A partial agonist still attaches, but it doesn't turn it on all the way, so it's fully attached. The best analogy for this is a dimmer switch. A full agonist turns the lights on all the way, 100%, like a light switch. It's either on or it's off. That's a full agonist. The partial agonist is like a dimmer switch. You can turn the light on up halfway, and let's say if your dimmer was broken, you couldn't give it any more. It only turns the light halfway up. If you have a better analogy for that, let me know. So partial agonists can actually, believe it or not, kick off a full agonist. And you might think, partial agonist, that sounds kind of weak. How could it kick off a full agonist? Just know that it can. A partial agonist can kick off a full agonist and take its place. Partial agonists can be good because they can be very safe. There is a ceiling effect. You can't turn it all the way up. So for side effects that can be dangerous, like respiratory depression, partial agonists are good. You will see partial agonists in addictions treatment. So you have binding to the receptor so it can reduce cravings, but you don't get the full high that may lead to you to respiratory depression or to making decisions that you may not otherwise make. And it can still give pain relief if that's what you need, but it doesn't give the full agonist response. One thing that I want you to remember from this slide is that partial agonists can kick off full agonists. Some more definitions that are pertinent in this class: synergistic and additive effects. There are questions about this on our first quiz. Additive effect, this is pretty intuitive. When two drugs are taken together, the total effect is the sum of each. Synergistic effects is a little bit different. Synergistic effect is like saying the whole is greater than the sum of its parts. So if you took drug A and drug B, kills 20% and 30%. If it was an additive effect, it would kill 50% of bacteria. There are some meds that work together in such a way that when you give them together, they work better than both of them given separately. So that's what a synergistic effect is. So if you took alcohol and benzos at the same time, they give you much greater sedation and much greater respiratory depression than you might expect because they work synergistically. If you give, the nickname for this is amoxiclav, it's two antibiotics together. These work together stronger than given alone. So the whole is greater than the sum of its parts with a synergistic effect. Let's talk about how that works in real life. Lisa Rinna, she has a urinary tract infection with E. coli. That's the most common causative bug that causes urinary tract infections. She has been prescribed this antibiotic, abbreviated as TMP-SMX, orally twice daily. This is 2 different antibiotics in one pill. Why would that be prescribed? Because they work at different steps in the bacterial growth cycle. Basically, bacteria need folic acid to grow, so they block that from happening. They work at 2 different steps in the same pathway, and so that blockade works much better together than each of them alone. So these antibiotics have a synergistic effect. All right, now we're getting into naming meds or classing medications. So there's a few different ways to name, class medications. Basically, you can arrange them by two different ways, by the pharmacological class and the therapeutic class. So pharmacological class is, how does the drug work? Is it a beta blocker? Is it a selective serotonin reuptake inhibitor? Is it a vitamin K agonist? Is it a diuretic? Makes you pee? So that's the pharmacological class. It's basically the mechanism of action, just a shorthand version for the mechanism of action. Usually we talk about receptor types or enzyme interactions or agonist, antagonist, or where it works in the body with the loop diuretics you're talking about the pharmacological class. And then there's the therapeutic class, and that's the condition that the drug treats. And you can have the same med that's in several different therapeutic classes. So metoprolol can be for blood pressure and it can be for chest pain. Usually the therapeutic class has something to do with the disease or symptom being treated. So sometimes your clinical instructors or your instructors will say, what's the pharmacological class? What's the therapeutic class? It's just two different ways of describing the same substance. Naming medications is something slightly different. There's 3 names for pretty much every medication. There's the chemical name. I will never ask you a chemical name. It has never been pertinent in my nursing practice. Your clinical instructors aren't going to ask you chemical names. You do have to know generic names and trade names really well. So generic names, those are never capitalized. It's the non-proprietary name. Doctors usually use the generic names when they're writing prescriptions. Sometimes they write trade names, but usually it's the generic names. And then the trade name is the brand name created by the manufacturer. So if you go into the drugstore, you are going to see acetaminophen and Tylenol. And they're both 500 milligrams, let's say. The Tylenol is usually going to be more expensive because you could kind of think of it like a brand name product, but it has the exact same active ingredient. So it's acetaminophen, 500 milligrams. So trade names are always capitalized. Prototypes. So you are going to see that there are many medications that are in the same class. And you're going to hear the word prototype. And what does that have to do with anything? So the prototype is the drug that represents the entire class. So let's say you have 5 different beta blockers. One of those is going to be the prototype. It's the drug that's always mentioned as a reference point just to understand the drug, to learn about the nursing considerations. And the prototype is usually the most well-studied, the one that's most clearly defined, the first one that was developed. So if you hear the word prototype, it means what's the drug that we talk about when we talk about this entire class that has like 10 different drugs in it. What's the one that we're going to talk about as the one that can represent all of them? The prototype of a drug class can pretty much represent every drug in the drug class. So beta blockers, the prototype is propranolol. ACE inhibitors, it's captopril. I'm never going to ask you the prototypes of different classes, but you do have to know what that word means. It's the drug that can represent all the drugs in the class. Now we're jumping to pharmacotherapeutics. So we've moved away from pharmacokinetics and dynamics, and we're moving to pharmacotherapeutics. This is the use of the drug. Why are we giving it to the patient? What's the therapeutic effect? We give drugs, and physicians prescribe drugs with different considerations of what we want the outcome to be. There is a definition handout posted on Moodle that describes each of these words and gives clinical examples. You do need to look that over. There are questions on the exam that are formulated like, I'm giving a medication for this reason. What type of therapy is that? Is it acute? Is it maintenance? Is it supplemental? Is it supportive? There's multiple choice questions about that. So we give different medications for different reasons. Sometimes it's prophylactic to prevent something from happening. Sometimes it's empirical, which means, so to give someone empirical antibiotics means we're not sure what the bug is, so we're going to give a huge broad spectrum of antibiotics until we figure out what it is. So it's kind of casting the net wide to say something is empirical. So you need to know that handout. These definitions are also on a handout in Moodle. I've pretty well defined most of them in this slideshow and in our first lecture, but you have to know these definitions pretty well also, well enough to answer multiple choice questions about them. I have mentioned drug forms previously in this lecture in our discussion about absorption and distribution and first pass metabolism, and now we are going to get a little bit more into detail about the different drug forms. Sometimes nurses have a choice as to what route or what form they are going to give a drug. The doctor will write an order. You can give Gravol, PO, IM, IV, or you can give morphine, PO, or IV. But sometimes the doctor orders a specific route. So if the doctor orders a specific route, we have to follow that. If they give potentially 3 different routes or 2 different routes or 4 different routes, then it's up to our clinical judgment as to what route to give it in. And I'm going to tell some clinical stories to illustrate that. On Moodle, I have posted a handout regarding drug forms, and your textbook talks about it as well. This is just a general list of rules. You will come to know the advantages and disadvantages as you progress through your clinical practice. Review the handouts on Moodle definitely, because there's possible quizzes on the exam about them. But here's just some general rules. We know IV has a rapid onset. Oral, it's the most convenient, and it does happen to be the least expensive. Sublingual, it goes into the mouth, but it melts under the tongue. It avoids first pass metabolism. So it's absorbed right into the capillaries under the tongue. Rectal, good for local delivery if you want local effects. An example of that is I had a patient with Clostridium difficile overgrowth, a C. diff infection. So that causes prolonged intractable diarrhea. And diarrheal illnesses are extremely dangerous because you lose so much fluid. So the person was on vancomycin, powerful antibiotic for this, IV. It wasn't really working that well. So the doctor ended up ordering an antibiotic that was instilled directly into the rectum, directly where the Clostridium difficile overgrowth was. I told the story in the first class about ketorolac rectally for the gynecological surgeries is extremely effective. So rectal can be good for local delivery. Same thing with topical. I mentioned Rub A535 Voltaren. That's good right for the muscle that's sore. Transdermal, so you will see transdermal patches of fentanyl, nicotine, nitroglycerin, so you can get prolonged absorption. So you can have a fentanyl patch on for 3 days, for example. You are going to learn a lot in other classes about how you actually go about administering intramuscular and how that's different from intradermal. So I've just put some example pictures on this slide. You don't have to memorize this for this class. You don't have to memorize subcutaneous is 45 degrees and intravenous is 25 degrees. I just wanted to show you some of the things you'll be learning in different classes and how changing the angle of the needle changes the route of administration. On the right-hand side, I have different routes of administration, different examples of each route of administration. So oral, you can get it in a pill, in a gel, in a powder, in a tablet. There's so many different examples under each. So each route of administration has a different form. So what's an example of having to pick the route? Well, Teresa is 72. She has pneumonia and she has had a stroke, so she has some difficulty swallowing. She has a temperature. She's febrile, chest pain with coughing, and trouble swallowing pills. The doctor has ordered Tylenol either by mouth or PR, per rectum, every 6 hours. So it's ordered PO. This means I can give it as a tablet or a liquid. Both those formulations of acetaminophen are available, or I can give it with a rectal suppository. So as I think about this for Teresa, I think tablet form, people with strokes who have difficulty swallowing, and sometimes even just the average person, especially kids too, and elderly people can have a problem swallowing pills, even small pills. The liquid oral form is available to me. It's very easy to swallow and it's just as effective. Rectal suppository, I don't need to choose that because she's not vomiting. She doesn't have orders that she's not allowed to take anything by mouth. So she doesn't need it rectally. So now I need to choose tablet form or liquid oral form. And for Teresa, because of this difficulty swallowing, I would probably go with the liquid oral form, and both would be available to me to choose from. Another example, Dr. Wendy Osefo, Real Housewives of Potomac. She's 45, and she was admitted with severe nausea and vomiting because she had a migraine. She has not been able to have any oral intake. She's nauseated. She is throwing up. Even water is making her throw up. She has IV access. The doctor has ordered Zofran. Another name for that is ondansetron. Ondansetron is the generic name. Zofran is the trade name. 4 milligrams every 8 hours. I can either give it in a pill she swallows, an oral dissolving tablet. So it still goes into her mouth, but it goes under the tongue and it dissolves. I can give it intramuscular or IV as needed. So I have 3 different routes available. Oral tablet, definitely not. She can't even tolerate water right now. She can't keep anything down. Orally disintegrating tablet, maybe. She doesn't have to swallow it, but she may be too nauseated to even hold it in her mouth. IV is there. She does have IV access. So IV ondansetron is a great option. IM's another option, but this would mean poking someone with a big IM needle. And she already has the IV access there. So I would probably, in this clinical situation, give her IV ondansetron. Another example, Lisa Rinna, she's 60. She had a knee replacement. She's having 7 out of 10 pain. She's alert. The doctor has said strict NPO, which means nothing by mouth, except for sips of water. And she has an IV line in place. She has access. She's alert and can communicate. When a nurse says she has IV access or she has access, it means that her IV is working. So the doctor has ordered morphine 4 milligrams. I can give it PO, IV, or IM as needed. Well, I can't give it orally because she's NPO, which means nothing by mouth. I could give it IV. It has a rapid onset, and it is appropriate for post-surgical pain, really acute post-surgical pain. IM morphine, it's going to be a slower onset than IV, and again, I need to poke someone with a big IM needle, and she's in acute 7 out of 10 pain right now. So in this situation, I would probably go with the IV morphine. She has access, she's alert, she can't swallow anything, and why poke her with a needle if I don't have to? She already has IV access. Another example, Kyle Richards, Real Housewives of Beverly Hills. She's 32, she has asthma, she comes to the emergency room. She's short of breath, her airways are constricted. I know that because she's been wheezing, and she also has a cough. She was exposed to a pet, anxious, working hard to breathe. She's conscious, she's cooperative, but she's becoming fatigued. She's getting tired from all the work she has to do to breathe. I have salbutamol ordered. That's a bronchodilator, so it widens the airways, and I can use it for bronchospasm, which is what asthma is. I have 2 options. The classic puffer that you probably are familiar with, most people are familiar with what a puffer is, also known as an inhaler, also known as a meter dose inhaler. It's on the right-hand side, the green one. When you take an inhaler, you need a little bit of coordination. You need to be able to do a full exhale. You need to be able to do a smooth, controlled, slow inhale. And you need to be able to hold it in for as long as you can. 10 seconds if that's possible. So that's what an inhaler is. My other option is a neb, also known as a nebulizer, and it uses compressed air to break apart the liquid medication, turns it into aerosolized particles, which are teeny tiny little particles that get deep down into the lung tissue. It doesn't require any kind of coordination. It doesn't require holding the breath in, and it's really effective in patients that are in such acute distress they can't coordinate their breathing like that, or anyone with compromised airflow. So for Kyle Richards, the doctor has ordered inhaler or nebs. I'm going to go with nebulizer. Now we are moving into different physiological factors that affect how our body responds to medication. So older people, I mentioned how older people have different parts of pharmacokinetics, but now I'm going to teach you about Beer's criteria. Beer's criteria was developed as a way to identify meds that pose risks to people that are greater than 65, whose risks outweigh the benefits. And the purpose of educating doctors and nurses about Beer's criteria is basically so that we have older people being less exposed to meds that have a greater risk than benefit. Now, the one thing you have to remember about Beer's criteria, and it's on this slide, is the phrase risks and benefits. Sometimes there's some medications that are so needful, that are so priority, that even if they have risks according to Beer's criteria or according to any other criteria that's out there, even though they have risks, the potential benefits outweigh the risks. So Beer's criteria is not, you absolutely must not give these medications to elderly people. Beer's criteria is a way to understand that elderly people have a higher risk with these meds, and you need to know what those risks are so that you can do a risk-benefit analysis of prescribing these meds. Basically, it helps doctors make informed clinical decisions. It helps them know, hey, my patient is older than 65. He or she is going to have a greater potential risk taking this med. So now I need to decide, knowing that this person has a greater potential risk, do the benefits still outweigh the risks? And it also has on it Beer's criteria meds that should be dose adjusted for older people. So a young person may be able to handle a certain dose, an older person might need a different dose. Another thing pertinent to older age is polypharmacy. Polypharmacy is usually defined as taking 5 or more meds at the same time, and it's really common in elderly people who have chronic conditions, who have been prescribed a medication for a chronic condition, and then maybe that med causes 2 side effects. So now they're on 2 more meds for the side effects, and now they're on 3 meds, and then they have another chronic condition. That's called a prescribing cascade. You just keep going with the prescriptions. There's many problems with polypharmacy, as I'm sure you can imagine. Interactions, side effects, when medication regimes are complex, hard to follow, people don't adhere to them that well. The average grade reading level in Canada for people 18 years of age or older, and this is controlled for first language, is grade 8 reading level. So you may notice, and maybe you will notice now, when you read patient information pamphlets or information that's communicated to the general public, you will notice it's about a grade 8 reading level, because that's the average reading level of adults in Canada. And older people tend to have poorer literacy rates than younger people do. And there's many, many different factors for that. I'll give an example. My stepfather is 80 years old, and he stopped going to school, I think, when he was in grade 5, because he had to help his parents on the farm. He had many brothers and sisters. They had a farm. He had to help, and he never returned to formal schooling in that way. And he didn't need a high school diploma. He actually became a welder and a mechanic and a whole bunch of other jobs, so he didn't need a high school diploma or super high complex literacy skills. So that's just one example of how elderly people might have lower literacy levels. People on a lot of meds tend to go to the hospital more. People on a lot of meds have worse side effects, and elderly people do not have as much of a reserve as younger people do. So people that are elderly can have cognitive issues from being on multiple meds that wouldn't cause cognitive issues in a younger person. And then, of course, the cost burden. Many meds are covered, many meds are not covered. Here's some examples of meds that are on Beer's criteria. There's a class of medications called anticholinergics, and I'm going to teach you about those in 2 weeks. Many medications, even if they're not in the anticholinergic class, have anticholinergic side effects. So you can be taking 3 different medications, and they're not anticholinergics. They're not in that class of medications, but they have anticholinergic side effects. So if you're taking 3 meds that cause delirium, that have a risk of delirium, you may be getting delirium, and that can cause a huge cascade of problems for an elderly person. 70% of hip fractures happen to women. After a hip fracture, you have a 50% chance of never going home again, going to long-term care. You have another % chance of dying in the next 2 years, all from a unsteadiness from delirium, for example. So let's say we have a postmenopausal woman with very poor, her bones are very porous from osteoporosis. She's taking 3 medications. She gets a little bit delirious. She falls. She breaks her hip. 70% of people that break their hips are women. Now she has a 50% chance of never living alone again. So these side effects can have serious real world effects. Someone could be on several different medications that cause constipation. Older people do not tend to have the simply put, the sensors in their body that tell them when they have to go to the bathroom, or even tell them if they are constipated. Constipation can end up with fecal impaction. Fecal impaction can end up with a bowel obstruction. A bowel obstruction could mean you need emergency surgery, and now you have an ostomy appliance for the rest of your life because your bowel has become necrotic. So those are some pretty extreme examples, but they're both examples I have seen multiple times in my career. So they sound extreme, but I've seen them probably more times than I can count on both hands. Benzodiazepines, those tend to have a really strong effect on the elderly people. NSAIDs, antipsychotics. You will see older people on these meds because sometimes the benefits outweigh the risks. Let's say that someone needs an antipsychotic because they have a diagnosis of schizophrenia. They need it, or they are going to have an acute exacerbation of their schizophrenia. In that case, the benefit might outweigh the risks. This is all extremely relevant for nurses because you are going to work with a lot of elderly people who have polypharmacy. And so it's going to be very useful for you to know that all these meds can have stronger and more serious effects on elderly people, and that can guide your nursing interventions. Okay, Ramona Singer. She is 83. She has high blood pressure, osteoarthritis. She can't sleep, urinary incontinence, and a little bit of dementia. She was found on the bathroom floor. When she got to the hospital, she was confused. She had a fever. She couldn't bear weight, and she has a left hip fracture and also a urinary tract infection. So these are all the meds she's on at home. She was taking 8 medications, all perfectly acceptable for all her diagnoses, but there's just so many of them. She's on an antihypertensive med, 2 meds for joint pain, an antidepressant, a proton pump inhibitor, a med for her incontinence. She takes an antihistamine to help her sleep, and on a daily multivitamin. Several of these medications are on Beer's criteria. For example, the antihistamine, diphenhydramine, and oxybutynin both have anticholinergic effects. So together, they could have a synergistic effect and cause much more confusion, urinary retention, which probably led to her UTI, and sedation. So if you're confused and you're sedated and you have urinary retention plus incontinence, yes, you can have both those things together. It kind of makes sense how an 83-year-old might fall in the bathroom or trying to get to the bathroom, and now she has a hip fracture, and now her entire life has changed. So that's an example of Ramona Singer's polypharmacy. So in this case, it was a prescribing cascade. She was taking something for sleep that worsened her urinary retention and confusion because diphenhydramine has anticholinergic effects. Anticholinergics make it so that you retain urine. She's elderly, so she got confused. So then she got on the oxybutynin because of the urinary retention. And all of these things added together made her have impaired balance. She's on an anti-high blood pressure medication, so maybe she was a little bit hypotensive, so maybe she was dizzy when she stood up. And all this led to a very negative outcome for her. And here's some statistics that I want you to know about. Because before I was a nurse, I didn't understand why falls were so deadly to elderly people, and now I do understand why. 40% of patients need nursing home care after a hip fracture. 1 minute you're living alone and you're maintaining, maybe you have a neighbor or a daughter or whoever coming to check on you. A couple weeks later or a month later, you are in long-term care. So very, very negative effects from something as simple as a fall can lead to a hip fracture, and then someone's entire life has changed. Pregnancy, a physiological condition that is important when we consider pharmacokinetics. We know the placenta does act as a barrier. It's not perfect, but it does act as a barrier to protect the baby's immature metabolizing organs. It doesn't fully protect the baby. So medications can accumulate in the baby. They can cross the placenta and cause birth defects. This is just a very short list, but medications can and will cross the placenta. Now, there are some situations where medications cross the placenta, but the benefits outweigh the risks, and it would be a doctor deciding if, in conversation with the patient, are we still going to give this medication? Lactation. We know that breast milk can excrete drugs. It's not the primary way, but it can excrete drugs. Just like medications during pregnancy, use of medications while breastfeeding is based on a risk-benefit ratio. So what's an example of that? Let's say we have a mother with chronic depression and she took antidepressants through her pregnancy, and she needs antidepressants when she is breastfeeding. She wants to breastfeed, and she also wants to stay on antidepressants. So in that case, it would be a conversation between her and her doctor. Okay, what are the risks? What are the benefits? Is there something else we can do? Is there some protective factors we can do? Is there a different antidepressant, or do we have to stick with this one and just do the best we can? Another example, beta blockers. Mom has a heart condition and she needs a beta blocker to protect her cardiac muscle, but it's excreted in the breast milk. Is there something else we can do, or do we just have to understand, okay, we're putting the baby a little bit at risk to protect mom's heart? So those are some of the really complex conversations that doctors might have with pregnant and lactating women about medication use during pregnancy, postpartum, breastfeeding, that whole thing. Okay, I mentioned the cytochrome P450 enzyme system. They live in the liver. They break down meds. 450 is, I just included it here in case you wanted to know, it's just how these enzymes absorb light. 75% of the meds we take and 75% that are used in clinical practice are metabolized by cytochrome P450 enzymes. The amount of this enzymes can vary hugely between different ethnic groups. And in the next slides, I'll give examples. So there are ethnic and genetic variations in cytochrome P450, and I have a list of different groups at the bottom. So some people of Asian descent, Southeast Asian descent, all Asian descent, are very poor metabolizers of clopidogrel. It's just the way their cytochrome P450 enzyme system is, and it's just the way clopidogrel is. There are certain ethnic groups that tend to be ultra rapid metabolizers of codeine. So if you gave someone from North Africa, perhaps if they had this genetic alteration, a codeine, it may not even touch them. It may just be like taking a Tic Tac. Does not affect them at all. Some Caucasians are poor metabolizers of warfarin. These are just examples. You don't have to memorize these, but I just want to make you aware that ethnic groups can metabolize medications differently. The other thing that's important to know about cytochrome P450 is that medications can impact cytochrome P450. So there's meds that inhibit these enzymes, and there are meds that speed up these enzymes. So an example of a food that affects cytochrome P450 is grapefruit juice. You may see with some medications, if you look them up in your drug guide, do not take with grapefruit juice. And this explains why. So grapefruit juice inhibits one of the cytochrome P450 enzymes. So it's not being taken apart and made inactive because its enzyme has been inhibited. So that means it's going to be more bioavailable, and that means you have an increased risk of toxicity. I wanted to give you some examples of cytochrome inhibition, and the best way I could do that was with a concept map. So in the black, I have the general concepts. So you take drug A, and it inhibits cytochrome P450. So you have to take drug A, it's prescribed to you. And then you also have to take drug B, and drug B relies on cytochrome for metabolism. What's going to happen then is you are going to have a slow metabolism of drug B. It's not going to be taken apart and made inactive at the same rate as it normally would or should. And that means you have more active drug floating around in the bloodstream of drug B. And so you have potential toxicity of drug B. So what's an example? Erythromycin is an antibiotic, and it inhibits this cytochrome enzyme. If you took erythromycin and simvastatin together, simvastatin relies on those enzymes. What you're going to end up with is a lot of simvastatin, a lot of active simvastatin floating around. One of the effects of a toxic level of simvastatin is a lipid lowering agent, is muscle breakdown. And the extreme form of muscle breakdown is called rhabdomyolysis, and it causes kidney failure, and it's very, very, very serious. So erythromycin and simvastatin, you can't take them together because erythromycin inhibits cytochrome P and simvastatin relies on it. Another example, here's the grapefruit juice example. Grapefruit juice inhibits it. If you took a calcium channel blocker, you don't have to memorize these examples, I'm just using them to teach you. You would have increased levels of the calcium channel blocker. Calcium channel blockers lower blood pressure. So if you had way too much of them, you would have a dangerously low blood pressure. So this is how cytochrome inhibition causes an increased risk of toxicity for the drug that relies on cytochrome P450 enzymes. Cytochrome induction. There are some medications that supercharge the cytochrome P450 enzymes. It makes them work more, it makes them work faster. So you took drug A and it induces cytochrome. And then you took drug B, and drug B relies on cytochrome. So now you have cytochrome P450 that is supercharged. They are working so fast and so hard. So drug B is going to be super metabolized. It's going to be broken apart and made inactive super quickly. So you're going to have a decreased effectiveness of drug B. Rifampin is an antibiotic that's used for tuberculosis. It's the primary antibiotic that's used for tuberculosis. It induces cytochrome P, one of the cytochrome enzymes. Oral contraceptives rely on cytochrome P. If you have your oral contraceptives super fast metabolizing and there's not enough in the bloodstream, which means not enough of the appropriate hormones circulating or not circulating, you are going to have contraceptive failure. You're going to have a decreased effect of drug B. Carbamazepine, that's an anti-epileptic drug. It induces some enzymes. Warfarin is an anticoagulant. If you took them together, you would have not enough warfarin, increased risk of blood clots, increased risk of strokes. So I'm not going to ask you questions like, what's the relationship between carbamazepine and warfarin? I'm not going to ask you any questions about these drugs. I'm just using these drugs as examples to help you understand cytochrome inhibition and cytochrome induction. So what's in black, I could ask you questions about those concepts, but for this PowerPoint, I'm not going to ask you questions about these specific meds. We're not learning meds yet. We're just learning these general concepts.